Hey everyone, we're going to do a quick test of the screen here for the presentation. So just bear with us for 1 second.
Morning, everyone, or afternoon, depends on where you're joining us from. I am Bill Smith, Chairman of the National Health Board and the Alaska Area Representative to the National Health Board. It is my pleasure to welcome you to the 2021 National Tribal Health Conference, Indian Health Service Listening Session. Before we begin, please note that this session is being recorded. If you do not consider consigned to be recorded, you are asked to drop off the session at this time. Hawa'ata and thank you. And we'll just wait a few minutes to see if anyone wants to drop off and not be recorded. As customary, we will start this meeting off in a good way with an opening prayer. It goes, Creator, open our hearts to peace and healing between all people. Creator, open our hearts to provide and protect for all children of the earth. Creator, hold all of our children from the boarding schools in your arms and tell them that the little voices have been heard. Watch over our warriors that stand in harm's way, our military, our law enforcement, our frontline workers, and our youth and our elders and Mother Earth. Creator, open our hearts to respect for Mother Earth and all the gifts that she gives of the earth. Creator, open our hearts to the end exclusion, violence, and the fear among all. Remove hate. Hawa'ata. Thank you all for the gifts of this day and every day. Amen. During this session, we'll be speaking with Ms. Elizabeth Fowler, Acting Director of the Indian Health Service, and other key leadership from the agencies. We appreciate the engagement with Mrs. Fowler and the leadership team, and we look forward to discussing the host of issues that are important to our tribal nations. To lead this session, I'm glad to be joined by National Health Board Vice Chair, Councilman Nicol Lewis. And I want to see it.
Thank you, Chief Bill. As you mentioned, we have many issues that are extremely important, in addition to the ever-developing issues related to the public health emergency. There are a variety of other topics of discussion, topics such as mandatory funding, telehealth, IHS tribal consultation policy, health, IT modernization, among many others. As tribal leaders, we appreciate the time to have with IHS so that we can share our guidance and recommendations on a variety of issues. Sorry, my screen froze. This is a dynamic time, and we want to ensure that as tribal leader perspectives are heard, understood, and incorporated in the agency's work. In just a moment, we'll turn the floor over to Director Fowler to provide opening remarks and to introduce IHS staff that are joining her for this session. After these opening remarks, Ms. Fowler's team will provide some brief updates and additional information. And after that, we will open the floor to comments and questions from our audience. Like other listening sessions, we will follow a tribal protocol to invite our elected tribal leaders to make comments, share recommendations, and ask questions first. Once our tribal leaders have had a chance to speak, we will open the floor to other members of the audience. And now to provide us some opening remarks, it is my pleasure to introduce Mrs. Fowler. Mrs. Fowler is the Acting Director of the Indian Health Service. Mrs. Fowler is a member of the Comanche Nation with descendancy from the Eastern Band of Cherokee Indians. Ms. Fowler began her career with IHS in 1990 and most recently as the executive officer for the IHS Oklahoma City area. Ms. Fowler has received numerous awards from the IHS and HHS, including her Distinguished Service. She has received her Bachelor's of Science degree in Mathematics from the University of Maryland. Director Fowler, it is good to have you with us today, and thank you for making the time to be with us all for this important meeting and discussions with our tribal leaders. I will turn the floor over to you and your team. Thank you.
Thank you very much for that introduction. I appreciate it. Good morning, everyone. I'm happy to be here with you today. We're happy to engage with you during this listening session. It is important to us to hear directly from you, the tribal leaders. So I want to thank you for your participation. Our partnerships and relationships with tribes, tribal organizations, and urban Indian organizations are critical to our success. And what we hear from you as feedback during these sessions is important in our decision-making process. So we appreciate and thank you for the words that we're going to hear from you today and the guidance and counsel that you will provide. I want to commend the National Indian Health Board for bringing together such a large, dynamic group of health advocates for this week's Tribal Health Conference. The conversations and networking that will happen over the next few days are critical in improving the health and well-being of Native people throughout the country. I also want to give special thanks to today's moderators, Chief Bill Smith, who serves as the NIHP chairperson and Alaska area representative, and Councilman Nicholas Lewis, who serves as the NIHP vice chairman and Portland area representative. I'm joined by my colleagues at Indian Health Service this morning as well. We have many members of our senior leadership and office directors and subject matter experts from across IHS headquarters who will provide updates and participate in the discussion. I do plan to keep my remarks brief because there's a lot to discuss today and there's a lot of information that will be shared after I speak. But first, I want to affirm my commitment to ensuring that the tribal and administration's priorities are a continued focus of the agency. Much of what we hear at these listening sessions guides our work moving forward. Your advocacy for Indian health does not go unnoticed. And as acting director, I take my role seriously and continuously engage with Secretary Javier Becerra and other HHS leadership on the important tribal priorities that you all raise in these sessions and through our consultation sessions. I'm looking forward to our discussions here today, and I appreciate all that you do as we work in partnership to improve the health and well-being of our tribal communities and increase health equity across Indian country. And that is really the conclusion of my remarks. I just wanted to do a quick introductory set, but we have more that we will be presenting to you this morning. And so I'm going to turn it over to Mr. Ben Smith to ensure that we are able to continue with our updates this morning.
Absolutely. Thank you, Ms. Fowler. Our first presentation will now be from Dr. Christensen. So let's go to the next slide. And Dr. Christensen, our Chief Medical Officer, I turn it over to you.
Thank you so much, Ms. Fowler, Mr. Smith. Okay, next slide, please. It's so much of an honor to be here with you today. I want to talk just about two of these circles of strategy. We're going to talk about our detection and our treatment. Next slide, please. So our second part of our strategy, of course, is to always detect those positive cases of COVID. And this means we do two things. We test to diagnose actual COVID cases, and we provide screening and or surveillance to make sure that we're not missing any asymptomatic cases. The IHS and tribal facilities are now reporting a 9.3% positivity. We are aiming to get that back down below 5%, and it is slowly moving downwards, so we're encouraged by that. I want to report that we have performed over 3 million tests across Indian country, and we continue to do both diagnostic and surveillance work. Please note that we still have supplies for the distribution of rapid point of care testing, which would be the Illum and some of the Binax products, and they're still available through our supply center. So next slide, please. I just want to briefly mention the Delta variant, this is so much on everyone's mind every day, including my own. This is definitely the most common US strain, first appearing in February of 2021. It is now 99% of all new SARS-CoV-2 cases in the United States. So this is very highly transmissible. The infection rates are very high because this is acting similar to the old measles and chickenpox before we had really excellent vaccinations for them, where you could pass it on to 5 to 9 other people. Where our original COVID virus infection rates were much lower, it was around 2 people that you would pass it to, which is very similar to a common cold. What this has resulted in is increased hospitalization and unfortunately deaths. And this is 98% unvaccinated people that are being harmed by this Delta variant. Next slide, please. So the one new variant I just want to mention in case you've read about it is the Mu variant, originated in South America, Colombia and Peru. 2,000 to 3,000 cases in the United States. It does not seem to be escalating, which is excellent news, but we are going to keep tracking that kind of in the background. There is a CDC variant tracker that is accessible to the public. If you want to look at the percentage of cases in your region, it will break it down by variants in all the regions of the United States. Next slide, please. So briefly, I want to talk about treatment. Number one, that's very, very important to us, a very big priority, is our culturally competent trauma-informed care. We want to encourage everybody to always address everybody with respect and understanding of what everyone has been through historically and certainly during this COVID pandemic. We encourage that we continue surge planning. We seem to be getting through this latest surge well, and I'm happy that it seems to be improving. I want to let you know we have all the therapeutics that are available across the country. We do have them in our supply center or can make that connection with our prime vendors. We use our antiviral is remdesivir. The glucocorticoid that everyone should have in their clinics and hospitals would be Decadron. And then we have all of the monoclonal antibodies available for distribution. We maintain readiness. We're always looking at emerging treatments. If you ever want to read up on them, they are on our IHS.gov website. So there's more scientific information if you choose to follow up. I want you all to know our critical care response teams are still very active, and they have been out helping both tribal and federal sites as needed throughout this latest uptick in COVID cases. I do want to mention, because say something very positive today, there is a new oral antiviral called molnupiravir, which is being trialed by Merck. And we hope that in the coming months, this will get approved for use, and this could be treated with an oral pill. So that is very promising for all of us. Next slide. Thank you so much for your time, and I'll be available for questions. I'll turn it back over to Mr. Smith. Thank you so much.
Thank you, Dr. Christensen, for those important updates. We are now going to transition into some programmatic updates, but a lot of this stems on our tribal consultation and urban confer policies at the Indian Health Service. The United States has a unique legal relationship with Indian tribal governments as set forth in the Constitution of the United States, treaties, statutes, executive orders, and court decisions. An integral element of the government-to-government relationship is that consultation occur with Indian tribes on issues that impact them, and that Indian tribes participate in the decision-making process to the greatest extent possible. If we can go to the next slide, I do want to point to the process that we utilize. For tribal consultation, unfortunately, we do not have a legal definition, which is why we have developed policies to implement tribal consultation within the IHS. As for conferring with urban Indian organizations, the Indian Healthcare Improvement Act through the 2010 amendments did provide a legal definition of conferring with urban Indian organizations. And what is interesting with that definition and our policies is that we focus on the principles of trust, respect, and shared responsibility through this enhanced form of communication. Through the Indian Healthcare Improvement Act's definition of national Indian health policy, in the general provisions, it states that we're required that all actions under the chapter of the Indian Healthcare Improvement Act shall be carried out with active and meaningful consultation with Indian tribes and tribal organizations and conference with urban Indian organizations to implement this chapter and the national policy of Indian self-determination. I want to pause there because I think that is such a powerful statement in that through these two communication mechanisms, the ultimate goal is really to underscore and effectuate the policy of Indian self-determination. The law continues to clarify the agency's role, including that of the Indian Health Service Director, specific to advocacy and consultation. In fact, the Indian Healthcare Improvement Act speaks to the position of the IHS Director as being established in a manner consistent with the government-to-government relationship between the United States and Indian tribes, and facilitate advocacy for the development of appropriate Indian health policy and promote consultation on matters relating to Indian health. This conference is one way that we're doing that, in that we have a number of topics that we want to discuss. On this slide, our consultation policies and conferring with urban Indian organization policies are triggered by a critical event. This could be an annual appropriation. This could be a change to law. This could be a request by a tribal government or by an urban Indian organization on needed changes. And so once that critical event is defined and acknowledged, then an announcement is needed. Through the Indian Health Service, we typically do this by issuing a letter to tribal leaders or issuing a letter to urban Indian organization leaders. And then we will proceed in gathering input. Listening sessions is a great example of one way that we do that. There may be instances where we need targeted feedback, so we'll ask specific questions. Gathering this input and then working through our deliberations to make a decision that is incumbent upon the federal government to do so is important. But finally, reporting the outcomes is equally important. You're going to hear in a minute or two some targeted areas through our IHS program directors and subject matter experts. But a couple tools that I want to bring to your attention is that we are doing our best to update our IHS event calendar of upcoming tribal consultation activities or urban confer activities. In fact, this month in October, there are a number of activities already being placed on the calendar. If you haven't seen already, on September 20th, IHHS Assistant Secretary for Preparedness and Response, Don O'Connell, announced tribal consultation on recommendations to facilitate access to medical countermeasures and supplies that may be needed in public health emergency. This consultation is focused to identify gaps in the request process for the Indian Health Service, tribal health programs, and urban Indian organization healthcare providers, and recommendations on how to close gaps to meet the ongoing needs of the current COVID-19 response, as well as future public health emergencies. On the IHS event calendar, you can find the two sessions that will be held on October 18th and 20th for this important consultation. In addition, as recently announced by Secretary Becerra, two additional sessions will be held on October 27th and 28th. And for this, the White House Council on Native American Affairs and the U.S. Department of Health and Human Services In his letter, Secretary Becerra invites you to join us for a 2-day virtual nation-to-nation dialogue to share your input, recommendations, and perspective on how federal resources and assistance can best support tribes' response to public health emergencies and improve health systems across Indian country. This dialogue will inform the work of the White House Council on Native American Affairs Health Committee to develop expeditiously an interagency plan to improve health systems, infrastructure, and to prepare for the ongoing COVID-19 and future public health emergencies in Indian country. So we invite you to these sessions. And my last update for you is some breaking news that occurred just at the end of last week. The 2010 Memorandum of Understanding between the Indian Health Service and the Veterans Affairs Veterans Health Administration has now been updated and signed. I know there's a second listening session with VA later this afternoon, and so you may hear some more information about it. But please watch for an upcoming letter to tribal leaders and to urban Indian organization leaders that will announce this historic moment in our efforts to work closely with our federal agency counterparts at the Department of Veterans Affairs as indicated within the Indian Healthcare Improvement Act. And with that, I'm going to take us into our targeted programmatic updates, starting with our Chief Information Officer, Mitchell Thornbrew. So if we can advance to the next slide, I will turn it over to Mitch Thornbrew. Thank you.
Thank you, Ben, and good morning, everyone. Go ahead and go to the next slide, please. I want to talk about our Health IT Modernization project to provide a little bit of additional information and background for those on the phone. The slide shows the current funding levels. So we continue to work with our partners to understand the scope and needs across the country and develop the right level of funding to have a successful replacement for the RPMS infrastructure and related systems. And again, looking at commercial off-the-shelf software in order to stay current with modern capabilities and digital capabilities that are prevalent in the industry, and make sure we have the best tools possible to provide healthcare to Native Americans. So just quickly, we started out in FY 2020 with $8 million of recurring funding. That was augmented quickly by the CARES Act with $65 million that was one time to accelerate the project based on our FY 21 request. And then in FY 21, we were able to increase that from $8 million to $34.5 million recurring. And that's still working on full funding for the project. So that seems like a significant amount of funding, but that it represents a small percentage of where we would like to be ultimately. And then the American Rescue Plan Act provided $70 million one time for the IHHS electronic health record. In addition to those funding that's going to the Modernization Research Project, I also want to point out that $141 million from the CARES Act and the American Rescue Plan Act was distributed to all of the ITU sites in FY 21 for telehealth and technology needs. Next slide, please. And just a reminder and list of the HIT modernization milestones. This journey began in earnest in November of 2019 with the Modernization Research Project, where we did complete 25 site visits and visited every area across the country to hear everyone's comments and thoughts about modernization and really help lay the foundation for the knowledge and baseline for the replacement project. We also held additional listening sessions and a couple of Dear Tribal Leader letters. I'd point out the April 1st decision memo were based on tribal consultation and urban confer, and really a consensus across the country that we need to fully replace RPMS, and we were able to render that decision memo and start the procurement process or acquisition process planning in earnest. So we did hold an RFI, a request for information, where we asked industry and our partners about what it takes to modernize, and so we got great information. We also conducted a congressional data call concerning tribal adoption of COTS EHRs in May, and held a virtual industry day with over 300 attendees, 200 companies. Again, lots of interest in the modernization project for Indian Health Service. And so we're happy to have that level of engagement, both with industry and our partners. And then we held additional listening sessions in June on the 15th and 17th in preparation for the next steps in the acquisition planning phase. And we saw that come together at the end of July, beginning of August, with a draft statement of objectives that we published, and we received comments back from industry and our ITU partners. So I want to thank everyone that responded to that. We are going through those responses, and that is being used to develop the final statement of objective, or the RFP, request for proposal, that will be coming out. So I'll go ahead and go to the next slide. And so that leads us to kind of our contracting strategy, again, replacing that health information technology platform. We plan for that request for proposal that I just mentioned, which will be in the form of the statement of objectives, to go out in the first quarter of FY 2022, towards the end of the first quarter. So that will be in most likely in December. So we do anticipate a single award IDIQ. So these are large government contracts that would allow us to manage almost decade-long project with some consistency, and so that we can execute well over that timeline. We do anticipate numerous teaming opportunities and small business opportunities as the result of that contracting strategy. So just wanted to give everybody a little bit of background about that. And go ahead and go to the next slide for my final comments here. As we talk about that contracting strategy, certainly we've had input into the RFP that will help address the scope and concerns around the country that are being brought forward. But also want to reinforce that during that selection process, we are building in robust tribal, urban, and federal at the field level involvement in the review of those systems. So we're having to do all the prep work, all the government acquisition work with some of our partners. But once that goes out, and then in second quarter of next year, we anticipate lots of folks being involved in the review of those responses during the acquisition process and prior to us making a final selection of that core replacement of our electronic health record. And again, the modernization project is doing much more than just replacing RPMS. It's really laying the foundation for the next generation of data interoperability, and making sure that we have the digital capabilities, both for patient care, but also at the national level, to provide the best healthcare possible. But I did want to reinforce there will be significant involvement of our tribal, urban, and our partners out in the field to make sure that that's successful. And with that, I'll leave you with just additional information. Again, a large project, a lot of information that we can share. We have provided a lot of this detail to NIHB and appreciate their help and support as they help get that information disseminated and conveyed out. But the link to the website is here, as well as the email address if you have any additional questions. And there's a sign up URL for that HITMOD listserv if you want to keep track of the latest updates as they come out. And with that, that'll conclude my remarks about modernization, and I will turn it over to Ms. Jillian Curtis. Thank you.
Good morning, everyone. It's wonderful to be with you all today. Happy fiscal new year. I'm going to provide a brief budget update that touches on our FY 2021 year-end closeout process. We'll talk a little bit about FY 2022 Hill action, and then I'll close with just a couple updates on our consultations in the budget space, including Section 105L and mandatory funding policy. So moving on to the next slide, let's go ahead and get started with FY 2021 year end. So we did complete a number of funding allocations at the end of FY 2021, consistent with the direction in the Indian Health Manual, and also to make sure that all of our CARES Act resources were going to be fully expended across the country. So we did go ahead and allocate some remaining headquarters CARES Act funding, as well as our FY 2020 Director's Emergency Fund, Management Initiatives, and Current Services Balances. So we haven't, I don't believe we've allocated Director's Emergency Fund or Management Initiatives funding at the end of the fiscal year in a couple years past, but this year we did have some balances, so we went ahead and made sure that those funds were allocated using our tribal size adjustment formula consistent with our previous practice. And we also did have the FY 2020 current services funding that did go out the door towards the end of September. There's a lot of detail here. We will publish a Dear Tribal Leader and Urban Indian Organization Leader letter in the coming weeks that will detail and document all of these allocations, and so that we can all have that for ease of reference. But the big picture here is we work to carry out our existing processes to allocate these additional resources across IHS, tribal, and in some cases, urban Indian health programs, and really make sure that those dollars were being used to put to their highest use. One note that I want to touch on here before we move on, I know we've gotten some questions about this, so I want to address it up front. The FY 2020 current services funding did go out as non-recurring. That was a decision that was made simply to streamline that disbursement process. It's not intended to be a departure from our overall approach or policy for current services funding, and we do expect those dollars to go out on a recurring basis starting in FY 2021. So rest assured, this was really just a technical decision that had to be made due to timing at the end of the fiscal year, and it's not a departure away from our overall principles for current services funding. We will be getting those dollars out on a recurring basis starting with FY 2020. Starting with our FY 2021 funds, which will be allocated in this fiscal year, FY 2022. Moving on to our next slide, I'm going to talk about the Hill action that's going on for FY 2022 right now. So as everyone here knows, the president signed the FY 2022 continue. I'm sure we were all holding our breath together to make sure that that was getting done before the end of the fiscal year. The Act does fund the government through December 3rd, and it includes a funding anomaly for IHS that would provide the prorated amount of staffing and operating costs for 3 facilities that would receive those dollars otherwise under the period of the CR. So we, of course, have the Yukon-Kuskokwim Primary Care Center in Bethel, Alaska. Bethel, Alaska. We have the Northeast Ambulatory Center or Salt River in Scottsdale, Arizona, and a corresponding amount for the Phoenix Indian Medical Center in Phoenix, Arizona. So Congress did provide the dollars that would be necessary to support those staffing and operating packages under the period of the CR. This is consistent with their prior practice, so we're glad to see that Congress went ahead and provided those resources in this 3-month or so CR. On the next slide, we will touch base on the 2 outstanding appropriations that are currently under consideration in the House and Senate. 3 bills now at this point. So the Senate has not yet published its FY 2022 Interior Appropriations Bill. So we are sort of waiting with some excitement to see what the Senate markup will include for the full year appropriation. And we're hopeful that Congress will hear the voice of tribal and urban Indian organization leaders and put that advanced appropriations proposal from the president's budget in for FY 2023. I think that the run up to coming into FY 2022 with the uncertainty around a CR or a possible lapse in appropriations really underlines the need for that advanced appropriations proposal. So we're hopeful that might be included in the Senate markup. As everybody here knows, Congress is also considering 2 other major funding actions. The first is the bipartisan infrastructure bill, which the current draft that was passed by the Senate includes $3.5 billion for IHS sanitation facilities construction. Huge funding level. It could potentially fund all of the projects currently on the sanitation deficiency system. So we're really waiting with bated breath once again to see if the House will move forward with a vote to pass the budget infrastructure bill, the bipartisan infrastructure bill as well. Tied up with the bipartisan infrastructure bill right now is the second budget reconciliation bill, which has been a hot topic in the media, especially over the last week or so. The current version of the bill includes about $3.5 trillion in spending. We don't have visibility on how much of that funding might come to the IHS, but we know that the Senate budget resolution did include $20.5 billion for Indian programs. So we're hopeful to see a significant investment in IHS needs as well. There is some talk right now about potentially resizing that bill based on some negotiations with moderates in the Senate. But we, again, don't know much more than you all are seeing in the media at this point. So we will be standing by to provide any technical assistance that the House or Senate may request as part of that process. And then lastly, we'll go ahead and touch briefly on the two active consultations that we have operating right now under sort of OFA's purview, which is on the next slide. The first, of course, is our mandatory funding policy consultation, which we wrapped up in the beginning of September. So we did receive some incredible, very helpful, insightful recommendations and comments from tribal and urban Indian organization leaders during this consultation, both during those consultation and confer sessions, as well as in writing. We're in the process right now of reviewing and summarizing all of those comments and considering next steps. But overall, I think I can share that some key takeaways or some common themes that we've seen in that consultation and confer process so far has been, one, a desire to capitalize on the current political moment. Strategically, this might be a good opportunity to move forward with the mandatory funding proposal, while at the same time balancing that strategy with a desire for some additional analysis on some key questions. We've also seen a common theme of a request for a tribal federal work group around developing the policy. And we have seen some commonality around the desire to have an appropriation for mandatory funding that would be appropriated through the authorizing committees through a legislative change, as opposed to through the annual appropriations process. So much more to come there. We're diving in, and we're really looking forward to sharing some next steps once we're able to finalize those and sort of get more into the details of a potential proposal and tribal and urban Indian organization leader feedback. On our Section 105L lease policy consultation, we are working in partnership with the Department of Interior to review comments that came in through that tribal consultation, both in person, or excuse me, virtually and in writing, so that we can identify possible areas for collaboration between the two departments, as well as next steps. We did see some commonality in the comments that IHS and DOI should have similar policies where possible. So we're making sure to do a careful review of those comments to see where we might be able to collaborate and partner on some similar, if not identical, policy approaches to 105L leases. So with that, I am going to wrap up my comments. I look forward to any questions that you might have, and I will turn it over to Mr. Daryl LaRoche. Thank you.
Thank you very much, Ms. Curtis. Thank you very much for the opportunity to talk to you all this morning about our partnership with the Bureau of Indian Education over the past year. So next slide, please. So we started off in January of this year holding weekly calls with Director Tony Dearman of the BIE and his leadership staff to get an idea about what types of support that he needed for the openings of schools and vaccinations of staff and students and so forth. So we started our meetings back in January and have been holding these weekly meetings ever since. The initial meetings had focused on getting the BIE staff and teachers vaccinated. So we are happy to see that by June of this year, they had over 3/4 of their staff had received their vaccinations. Then we started with helping with their school reopening plans and providing more of the clinical information and providing them updates on the vaccine status and so forth, getting individual schools in touch with our area vaccine coordinators to host events and so forth, so that we made sure that we had good coordination on that. And more recently, we've been working with them. They have 4 off-reservation boarding schools, or what they call orbs, Sherman Indian School in California, Chemawa Indian School in Oregon, and Riverside School in Oklahoma, and Flandreau Indian School in South Dakota. So we had started working with them on their reopening plans, along with the Centers for Disease Control and Prevention. They have their tribal support section as well as their school reopening group. So we've been working together with them to review plans and so forth to get them ready for their opening date of October 25th. So this week, the Bureau of Indian Education is actually hosting 2 vaccination forums, and these are open to their staff, students, and parents. And one's on Wednesday and one's on Thursday, the 6th and 7th of October. And we'll be supporting along with our CDC colleagues. So it's been a very good partnership so far, and we really do look forward to continuing this partnership going forward. So with that concludes my section. I'll pass it off to Mr. James Lvington.
Good morning, everybody. I'm James Lvington. I'm the Director of the Office of Environmental Health and Engineering. Can you go ahead to the next slide, please? So Ms. Curtis from OFA has already talked about the potential of the congressional infrastructure bill. There's the potential in the bill to fund the $3 billion in sanitation needs, and also there's potential for funding for healthcare facilities all the way up to the grandfather list, which is $2 billion. The current healthcare facilities need from the 21 report to Congress is about 26.8 billion. Next slide, please. So for sanitation facilities in 21, we received $169 million to put towards the $3 billion need. In the infrastructure bill, there's a proposed $3.5 billion amount to cover that entire IHS SDS list. So hopefully, whether we get the full amount or some of it, we'll be making considerable progress on sanitation facilities in the next few years. Next slide, please. Oh, before I turn it over to Francis, let me also just mention in 21, we got $260 million for healthcare construction that we're applying to the grandfather list, but plus we have some funding for quarters construction and SAP applications, the small ambulatory program every year too, which is another great funding source for smaller facilities. And then with that, I'll go ahead and turn it over to Admiral Frazier. Thank you very much.
Thank you, Mr. Ludington, and thank you for having me on to provide brief updates today. I'll just provide some brief updates on COVID-19 boosters, testing, and treatment. So if we could go to the next slide, please. Thank you. The IHS continues to focus on vaccination efforts, of course, with our first and second doses of COVID-19 vaccines. And again, we're ensuring protection from severe outcomes, including hospitalizations and death. In accordance with CDC and FDA guidance, we're offering the third dose vaccinations for individuals who have weakened immune systems and booster doses of vaccine, Pfizer vaccine for individuals with certain groups listed here. So hopefully you find this slide useful, trying to summarize it up in a very useful manner for consumption. So as listed here, boosters are likely most beneficial for people 65 and older and those who may have other risk factors. The CDC recommends that people 65 and older, or those living in long-term care facilities, and individuals who are, if you see in the green there, 50 to 64 with underlying medical conditions should be vaccinated. Additional groups may get a booster if they are 18 to 64 and have underlying medical conditions or at a high risk for occupational exposure or exposure due to living in close quarters with others. IHS continues to work with tribes, tribal leaders, areas, and our federal partners to ensure that we're providing the most up-to-date guidance. We will provide that information as soon as we're aware as things evolve regarding COVID-19 vaccine. And so we're monitoring that landscape regarding vaccines, and we will issue updates as soon as we get that additional information. We're waiting on additional information regarding boosters for 2 other COVID-19 vaccines authorized by the FDA. We anticipate the boosters for Moderna will be reviewed by the FDA in the fall, and data for the Janssen J&J vaccine may come forward in early winter, perhaps as early as November. So we're waiting to see what happens with those, with the recommendations there. If we go to the next slide, please. So just another a couple quick more updates. IHS is working with the National Supply Service Center to procure and distribute testing supplies and various COVID-19 treatments, including monoclonal antibodies across the IHS system. We do have a robust testing system in place with easy access for testing at IHS facilities around the country. The rolling 7-day positivity rates are approximately 11%, and rates are updated twice weekly and listed by area, and they're posted on the IHS COVID-19 webpage. So do please take a look at that for the latest information, and we will continue to post that information there. At this time, the National Supply Service Center continues to meet the demand for needed testing supplies and authorized treatment products. We will continue to communicate with IHS, with tribal programs and urban programs to assess logistical needs and to coordinate any requests. The National Supply Service Center also continues to monitor the national supply chains and leveraging existing partnerships and contracts. And we're doing that to meet the logistical needs that are identified. With that, I look forward to any questions. I will turn it over to Ms. Terry Smith to provide her update, or I guess Ms. Jennifer Cooper. Thank you. Over.
Good morning, everyone. And I, again, want to thank everyone for the opportunity to just give a quick update on the IHS consultation policy and the consultation of that. So next slide, please. And as you can see from all the various consultations that have occurred and are in process right now, the IHS is strongly committed to regular ongoing travel consultation. And in April, the IHS initiated consultation on the 2006 IHS travel consultation policy and consultation process. This was done in response to both a joint letter from the Tribal Self-Governance Advisory Committee and the Direct Service Tribes Advisory Committee, recommending a joint tribal federal work group to review the policy And also the recent January 2021 presidential memorandum on consultation and strengthening nation-to-nation relationships. During the initial comment period, the IHS held a virtual session to gather input, and also we did receive 12 letters from across the country providing input on the consultation policy. Also, as part of our effort, the IHS has established a IHS Directors Advisory Work Group on tribal consultation. The work group's charge is to review the comments and also review the IHS tribal consultation policy and make recommendations on the policy, which will be shared in a subsequent consultation on the consultation recommendations. Chief Malerbo serves as the tribal co-chair, and Mr. Ben Smith serves as the federal co-chair. The work group has met virtually twice, and our next meeting is Tuesday, November 2nd. And lastly, I wanted to highlight some updates made to the IHS website's consultation page. In conjunction with the consultation review, the agency is also updating our web page, and in this first phase update, we have posted the membership list of various IHS tribal advisory committees and work groups. So over the fall, please look for additional updates to this web page on consultation. And if you do have any recommendations for information that you're looking for on consultation information, please feel free to send to the Office of Tribal Self-Governance or the Office of Direct Service and Contracting Tribes. And with that, I'm going to say thank you very much, and I'd like to turn it over to Dr. Riaki.
Great. Thank you, Jennifer. I'll be providing an update on the policy with conferring with urban Indian organizations. Next slide. Okay, as Mr. Smith noted earlier, with Congress reauthorizing and amending the Indian Health Care Improvement Act, they added a requirement that the IHS confer to the maximum extent practicable with urban Indian organizations in carrying out the ICIA. Confer means engagement in an open and free exchange of information and opinions leading to mutual understanding and comprehension, and emphasizing trust, respect, and shared responsibility. In September of 2014, IHS established the policy on conferring with urban Indian organizations, which is in the Indian Health Manual, and the policy provides guidance to the agency for seeking input from urban Indian organizations to ensure that the healthcare needs of urban Indians are considered at the local, area, and national levels. So the IHS is currently revising the policy on conferring with urban Indian organizations. IHS initiated Urban Confer on April 27th of 2021. We held a virtual Urban Confer session on June 9th with a comment period ending on June 15th. So the agency has reviewed those comments received from urban Indian organizations and will be issuing another letter to them, which will include the revised policy, which incorporates their feedback during the Urban Confer session and written comments that we received. So that's the latest update on our policy. Looking forward to initiating additional Urban Confer on the policy and strengthening it even more. So I will turn over it to Captain John Rail for the next update. Thank you.
Good morning, everybody. I'm going to give you an update on the telehealth reimbursements. Next slide, please. As you all know, our facilities rely heavily on our third-party revenue, and most facilities need a constant flow of the third-party revenues to sustain their services. So as a result of the public health emergency, overall face-to-face encounters decreased and visits conducted via telehealth technology increased. So we call that telemedicine, which included telephone and telehealth utilization, and the volume is not equal to the face-to-face encounters, which led to really a lower collections in a lot of the facilities. Also, telemedicine services have different billing and payment methodologies, which may have also lowered collection levels. So CMS created telehealth flexibilities for Medicaid and Medicare reimbursement. For the Medicaid flexibilities, states have the broad flexibility to cover telehealth services in their Medicare state plans. No state plan amendment was needed to pay for these services delivered via telehealth if payment rates or methodologies do not differ from in-person services. So telehealth included a variety of services, including telemedicine, which generally involves two-way real-time audio-visual communications. Most state agencies have implemented telemedicine and are reimbursing IHS accordingly. However, telemedicine visits have not completely replaced the number of face-to-face medical visits that we lost during that public health emergency. Some states pay the OMB rate for some services and others elect to pay at a fee-for-service rate. For the Medicare flexibility, CMS waivers increase the types of reimbursable to telehealth services under Medicare and remove geographic and site of service restrictions. So with that, really, what we've done is we've also worked with CMS and posted the telehealth billing guidance on IHS.gov. So we're continuing to seek feedback on any kind of issues that you may be having with telemedicine and reimbursement with Medicare and Medicaid, and continuing to work with CMS on those issues. I will now pass it back over to Mr. Ben Smith.
Yes, thank you. I want to thank all my IHS colleagues for the updates and presentations. At this time, we'll end the slideshow. I'll ask our presenters to turn on their cameras, and I'm going to turn it back to our NIHB host, Chief Bill Smith and Councilman Nick Lewis for our facilitated conversation. With that, Chief Smith, back to you.
Thank you, Ben, so much for those updates and that important information. Now we'll start the discussion portion of the meeting. Our National Health Board of Directors have a few questions to start off with. I would like to invite my fellow board member, Councilman Nick Lewis, to ask the first question. Nicholas?
Thank you, Chief Smith. Just a comment. The current funding mechanisms, namely competitive grants, are problematic and do not honor the trust responsibility owed to tribes. The grant application process and reporting requirements put an undue burden on our tribes. Tribes should not have to compete against one another, our state, our counties for funding. The request that we have is allocation and distribution mechanisms should follow all federally recognized tribes to get funding. We believe this could be accomplished with a formula that is vetted through tribal consultation. Also, funding should be provided in ways with the least administrative burden to tribes. The agency must simplify the application and reporting process. And I guess one other way to frame that is the trust responsibility is owed to all tribes equally. Lummi, speaking from Lummi, we have a trust responsibility just like any of the tribes across the country. And that does not diminish one of the other tribes' treaty rights that they are rightfully owed as well. And when you're making us compete against one another, and that is in essence denying a tribe their IHS funding, that's a disservice. That's breaking the trust responsibility. And I don't want no ill will towards any other tribes or their trust responsibility weakened because IHS isn't funding them. And that's basically what competing against other tribes is doing. And so I hope there might be some response to how we can look at doing that a little bit different to make sure all tribes' trust responsibility and treaty rights are upheld. Thank you.
Ben, do you have a response to Nicholas's question?
Good morning, Chairman Lewis. Your words are well taken. Your point is well taken. We do understand the burden that is placed on tribes when they have to apply for grant programs. It's an administrative burden on the IHS as well. And I appreciate the points that you made regarding competing against one another and how you feel that it's diminishing responsibility towards tribes. I think that's something that we can have further discussion on. I think one thing that is a challenge when it comes to allocation of resources that have been allocated through the grant program mechanism, through the grants mechanism, has been the fact that those resources have been minimal at times. And so I think that is something that we would like to engage in further discussion on at some point. That is on our agenda for the coming year. So thank you for bringing that and raising that point with us.
Thank you. Thank you for that response. And now I'd like to invite my fellow board member, Samuel Moose, to ask a question. Sam? Jennifer, can we unmute Sam?
Seems like he's muted, Chief Bill. He has to just unmute. We can come back to him.
Okay. I have one additional question before we open the floor, or before Sam could come back on. We are seeing a dramatic shortage of providers due to the surge of COVID-19 Delta virus. We have already seen a serious provider shortage worsened by the COVID-19 pandemic, creating burnout in providers, but the number of rising COVID-19 cases has now stretched the ITU system to a critical standard of care. With higher cases, not only are there not enough providers, but our remaining providers are experiencing more severe burnout, and our providers with children are also having to miss work when their children must isolate due to COVID exposure to schools. So I have two questions for you. First one is what is the Indian Health Service doing to help migrate the support of tribal health organizations addressing the staffing issue? And the second question is, has the Indian Health Service made medical staffing requests to FEMA for tribal staffing support?
Thank you for that question as well. I think that is something that is being experienced in various places, locations across the Indian Health Service. And I know that it's a concern for both our federal and our tribal programs and urban Indian organizations as well. We do have the ability to request deployment in severe staffing shortage situations, and we actually have made those requests on behalf of both tribal and federal programs in the recent month or two. So that is something that is we are able to do, and we would need you to work with your area director on requesting additional resources, staffing resources, and then we maybe see what we can do to forward those requests through the process. I don't know, Ben, if you have any other comments about that.
Yeah, I think you characterized it and explained it well. Knowing if you are going to access or make requests for provider support through FEMA, knowing that tribal governments that do have declared public health emergencies do have a route specific to them, as well as working through the Indian Health Service. But working with your area director and your area emergency point of contact here, what we refer to as MPOC, is a good start in starting that collaboration. This is such an important topic, though, about not only provider burnout, but just provider shortages. And I'd like to invite Dr. Christensen to maybe weigh in on this, as this is an issue that is playing out across the country not only in the IHS federal space, the tribal health programs, but I think it's inherent just across the board. And Dr. Christensen, is there anything you would like to add on this important topic?
Yeah, thank you so much, Ben. This is obviously a very complicated and challenging problem. Certainly the burnout of all our frontline staff is inevitable. They've been exceptional in their response to COVID, but they are very, very tired. We do try to do some deployments of mental health support. We try to get them to have their time off and have others cover. And we've repurposed a lot of staff to help cover a lot of the activities using what I kind of call non-traditional providers, which our pharmacy staff has really stepped up, do a lot of the vaccinations. We've trained and educated others to help with those events so that we could pull our doctors and nurses back to the acute patient care that we all need for our patients. Certainly, everything that's been mentioned is an opportunity for access to more providers. And I want to throw out another possible source would be to look at your academic institutions in your areas. Sometimes you can work with them through agreement and they can have some of their doctors rotate in and give you some respite for your providers or augment your staffing. We've worked very well with that across the agency of having them rotate through and at least help us during the high points of COVID. And that may be an option for both tribal and urban sites as well to work with your areas on their agreements that they have. And of course, you tribals can actually move a little faster on the agreements than we can due to the self-determination and independence. So I suggest that as a stopgap to help you a bit with staffing. In the longer term, we are working on student pathways and ways to recruit more residents and young people into building our health force from within. And we actually have a summit this month to that end, where we're looking at ways to enhance mentoring and recruiting both public health and medical professionals into the service of Indian country. So we have, short term, and then we have our longer term projects, but we certainly acknowledge and recognize the stress that this has put on everybody. So thank you so much.
Thank you for those responses. And there's one other resources that I know of, and we spend lots of money on our military, and we have corpsmen that are back in the world again now that everyone is out of Afghanistan. And it is a deal where I've said in the past where an air traffic controller can leave a military job and step right into a civilian job. But as a corpsman, they have to go back to school for another 4 years before they can treat a civilian. But in the military, they can do miracles on the front lines. So it's just my thought as a veteran that I put my faith in the corpsman. Thank you, Awata. So thank you for those responses. And Dale, and if Sam, if you're there, you can ask your question. Sam, I see you're unmuted, but. AC, can we help Sam?
He's unmuted right now, Chief Bill. I'm not.
Okay,
Sam, if you're on the phone, you might have to press *6 to unmute.
Sam, if you're there, we can't hear you yet.
Chief Bill. We can move on and circle back if he can get himself unmuted.
Okay, Sam, if you can get unmuted, raise your hand when you have a question. And at this time, I want to thank our fellow board members for kicking off those questions. And I'd like now to invite the elected leaders in the audience to ask a question, share their comments, and provide recommendations. If you would like to speak, please put your name in the chat box and the National Health Board staff will unmute you and you can ask your question directly to our speakers. We ask you that please start by stating your name, your tribe, your title. Once you are muted, you also invite you to turn your camera on if you would like, so that we can all see you when you ask your questions. And I'll go for the first question. You see someone with a raised hand, or?
Yes, it looks like we have Chairman Ron Allen.
Ron Allen, you there?
Chairman Allen, if you're on the phone, you may have to hit *6 to unmute.
This is one of the main malfunctions with these Zoom meetings that we don't do in person. And it's I'm sorry for the. Ron, are you there?
Can you hear me?
Yeah, we can hear you now, Ron.
Okay. Thank you. I appreciate it, Chief. I appreciate all the updates. Thank you very much. So I only picked up part of John Rayo's update on the telehealth. Specifically, I'm interested in whether or not IHS is making any constructive permanent request to move the telehealth rate to the OMB rate, and so that we can collect the true cost of providing that health care for our patients.
Thank you for the question, Mr. Allen. Actually, we've as you know, we've discussed several things with CMS previously concerning the rate, especially when it comes to state and their flexibilities on the OMB rate. Really the CMS doesn't have control on what the rates the state set. So certainly those are still continuous conversations that we have with CMS and the abilities. And I think the message to push it out to states and their flexibilities with those rates that they determine for the telehealth programs. As you said, it varies from state to state, and CMS has let the states know that there is that flexibility.
For excuse me, John. So you mean for both Medicaid and Medicare? I thought that the CMS sets the Medicare rate at I could be wrong about this, John. At half the average.
Yeah, the Medicare rates are set by CMS. They do not use the OMB rate. The states have a little more flexibility on actually utilizing the OMB rate. So as far as we continue discussions with CMS, and I think it'll take continued discussions with them and also discussions, within our CMS groups that we have, such as TTAG, to continue to have those conversations with CMS.
Okay, and so you're having those conversations now?
I believe that we've had those conversations even within our groups, with the TTAG groups as well.
Okay, all right, I appreciate that. It's I think it's universal that we all want the rates adjusted, and as you well know, John, telehealth is it's here to stay. It's not just, we learned a lot through COVID because of COVID, but it's here to stay, and it really does improve our ability to serve our patients. Thank you.
Yes, sir. Thank you. And I just want to add that we also have been looking at an impact when it comes to all-inclusive rate and the way we calculate that all-inclusive rate. So we'll continue to work on those things as well.
All right. Thank you. I appreciate it.
Thank you. I think next question goes to Aaron Payman.
Hello, can you hear me?
Yes, we can.
Okay, I don't know if you're going to be able to see me or not, but and I even wore a jacket today. But Ani Boujou, I'm Chairperson Aaron Payment of the Sault Ste. Marie Tribe. Also I serve on the National Congress of American Indians.
Recording in progress.
National Congress of American Indians as an officer. I do see, there we go. And I wanted you to see my graphic in the back, Every Child Matters. Let me start out by saying I highly respect the work of the National Indian Health Board, and I hold several of them as friends, and I'm here because I was voluntold by Stacy. So Stacy's a member of my tribe, and if anybody knows Stacy, she's in charge. So glad to be here, Stacy. Just a quick reminder, I'm going to do two of these together because I think they're so integral. And it's advanced appropriations and mandatory funding. So as a scholar and a student of the federal Indian policy, the treaty and trust responsibility, when tribes entered treaties with the federal government, we obligated forever health, education, and social welfare for as long as the grass grows, the winds blow, and the rivers flow. And that is forever. And, you know, we have ebbs and flows with the government, with who's president or who's the House and Senate. And right now we're watching kind of this comedy of errors, a little bit of a clown show in Congress with trying to figure out whose proposals what. And none of that really should matter to the funding that the federal government is obligated to provide us. The funding that we get is just a little tiny dot in the big picture. We're minuscule in the overall appropriations. We have seen some really good proposals with this administration, so I want to acknowledge that. I don't want to diminish that at all. But I want to remind our partners on the call, and this is really preaching to the converted, because I know most of you on the call have heard this before, and I think most of you agree with what we're asking for mandatory and advanced appropriations. But when we signed those treaties, we obligated the federal government. And I would say that when we focus on the purchase and referred service area, you know, that's just the tip of the iceberg of what our need is in Indian country. We report statistics on the vaccination rates through our purchase and referred service areas. There is nobody collecting or reporting data on the American Indians in a coherent way with vaccinations across the Indian country that are not in our purchase and referred service areas. So the first step to avoid the impacts of sequestration would be to make our funding mandatory, because the last time that the impacts of sequestration and government shutdowns together, my tribe lost 6 providers. We lost a doctor, a nurse practitioner, and we lost 4 medical staff. And the instability of funding to tribes when the federal government doesn't fulfill their treaty and trust obligation is our doctors and medical providers realize that their funding is precarious. And then what they do is they circulate their resumes and they find so that they don't have to be interrupted in their funding. So this is avoidable. The federal budget crisis is not going to be made or broken on Indian country. So we need full funding and mandatory funding. So the first step would be to look to your tribal advisories who have done this work. Ron Allen is the person who you need to ask, the National Indian Health Board. What is our need? And that is really focused on the purchase and referred service area. So I can tell you, I can guarantee you that those numbers at about $48 to $50 billion for IHS is minimal, because it doesn't at all include my tribal members who don't live close to me. Like example, Stacy's a member of my tribe. She doesn't get any benefit financially from our tribe in health services unless she travels. And she did come, and she shared this, when she was vaccinated. She had to catch a plane, catch a limo or a cab, and then get all the way home, and then drive all the way north another 5 hours to be vaccinated. Because at that point, there was no plan to vaccinate Indians that live in Washington, D.C. And so the full funding is the first step, and then look to your tribal advisories on how to do that, and then make it mandatory. And we do appreciate this administration requesting mandatory funding. IHS should be first, but it shouldn't be last. All of BIA funding, all of CDC funding, all of special diabetes funding. Special diabetes should be permanently reauthorized. It's one of the most successful programs in Indian country. I'm from a family history of diabetes. I have a brother who just had his second leg amputated, and he's going to have to come live with me now because we don't have a provider for him. So advanced appropriations, mandatory funding as a treaty and trust obligation. I'm preaching to the converted, I know that, but what is it that we can do to help you to get across the finish line? We're in a unique opportunity with the House, the Senate, and President right now, and hopefully it'll be longer than a year from now. But what can we do to help you? And we stand ready to assist this administration, but we got to be bold in our ask. So that's it. Thank you.
Chairman Keenan, thank you for your questions and your comments. You're right that those of us in IHS, we are just as anxious as you are to accomplish the goals that we share with tribes on accomplishing advanced appropriations and mandatory funding. And we're hopeful that this year, well, in fiscal year 2022, that we'll see advanced appropriations be appropriated for fiscal year 2023 with the final appropriations for fiscal year 2022. And as you know, we recently completed consultation on mandatory funding for the Indian Health Service. And so we are diligently working on the follow-up from the consultation sessions. I think you're right. This is a point in time at which I believe that it's more hopeful than ever. I'm more optimistic than ever that these are actually goals that we can accomplish during this administration. I think that the ways that you can help us are to simply keep doing what you're doing in terms of keep raising it, keep talking about it. The more we talk about it and raise attention, bring attention to it, I think that those are helpful to our efforts to submit a proposal and actually see it accomplished. I did want to point out I have one point of clarification about a statement that you made. I just want to point out that sequestration is actually a third item that would need to be addressed. Even funding that is on the mandatory side of the budget is subject to sequestration. We've seen that with our special diabetes program for Indians. And as a matter of fact, I believe in fiscal year 2022, the funding dropped from $150 million to $147 million because of sequestration. It is limited. Some programs, they have a limited amount that can be sequestered, but it does affect programs on the mandatory side of the budget. So that's a separate item that also would need to be addressed. I think I'll stop there. I don't know if Jillian has any other comments, but just wanted to say those, make those responses to you.
Thank you, Ms. Fowler. I don't have anything to add at this time.
Okay, thank you.
Thank you for those responses. AC, is there anyone else up that has a hand raised or question?
Yes, we have Councilman Nate Tyler.
All right. Nate, are you there?
Yes, I'm here. Good morning, Bill.
Good
Chief
morning.
Bill. I had a problem getting onto the original invite, and I had to switch to Zoom. And this current Zoom's different than what I've used in the past. But so I missed the first maybe 30 minutes of the discussion, and I wanted to talk about the modernization of the health information technology. 79% of tribal facilities of health facilities in the IHS are tribal ran facilities. And I guess continuously talking about reaching out to the IHS to have the IHS bring us to the table, commit to us, tribal governments as being a partner in the project. Treat us level, treat us fair, and including IHS advocacy for the creation of funding streams that go directly to tribes. I think that's really important. And also retooling ISAC, developing a tribal advisory committee, and creating other transparent engagement processes to provide tribal engagement with project management office. That's managing the next steps in the health IT. And also a number of tribes have, and this has been mentioned numerous times, the tribes that already put money into their systems, there really should be a process for reimbursement. Tribes are a decade ahead of IHS as far as IT and EHR updates. So, and that's at their own expense. But just once again, involve the tribes and in moving forward. So, but once again, I apologize for being late. I had problems with on my end with technology. So, but I just wanted to bring up the IT.
Thank you, Nate.
Councilman Tyler, there's a great point that you raised. We do also want to ensure that we have stakeholder participation in the HIT modernization project. We are bound, because it's a federal procurement activity, we are bound by the rules that surround procurement sensitivity and procurement integrity that means that we just have to approach it in a different way. And so I'm going to ask Mr. Thornbrew to say a little bit about the process and having tribes involved in that process. And I also would ask him to speak to your comment about revamping the ISAC. We actually just did that fairly recently. So I would ask him to explain what we did there, and hopefully that will respond to your comments. So Mr. Thornbrew.
Thank you, Ms. Fowler, and thank you for those questions, Councilman Tyler. I appreciate hearing from you and appreciate your participation in the conversations, not only here, but in ISAC as well. Just to respond to the prompting from Ms. Fowler, certainly we want tribal urban partner input as well as our stakeholders in the field. This is the selection of our central EHR is not something that we want to do from an ivory tower without input from the care teams, providers, and all the staff that perform that work in the field. And so a lot of our work has been preparatory in the intense amount of work to bring to market a government contract of this size. That being said, as we look at that contract being put out in the first quarter of 2022, we're committed, and I can commit to you that providers, tribal, urban stakeholders will be able to review what we receive from that acquisition solicitation. So when vendors respond, we're forming the teams and creating the engagement space so that our tribal, urban, and field stakeholders can see those submissions, review them, and provide input back to us before we make that selection. In addition, we've engaged both the industry for their knowledge, but also our tribal, urban, and field partners to make sure that we get the requirements to go into that statement of objectives to design that system. So we continue to work on that, and I'll be brief. I know we're at time. Regarding ISAC, so in 2019, that charter was revised and added 12 additional tribal representatives, one from each area, appointed by the area director. So we've made a lot of headway selecting those. There's just a few vacancies now, and we're working with those area directors to get those vacancies submitted. But additionally, ISAC has the authority to make recommendations for further changes. And so we're open to that. It's not inappropriate to make additional changes as we move forward, but we would look to ISAC for recommendations to make those changes to the charter. And of course, it takes a little bit to review those and get those through, but that's an open discussion that we can have in ISAC. And with that, I'll turn it back over. Thank you.
Thank you for those comments. AC, do we have any more questions or comments?
I think we're at
I
time,
know,
Chief
I know
Bill.
our time is just about up.
Yes, I think we're at time right now.
We do have time to take a couple more questions, right?
I don't think we have much more time to take questions, Chief Bill. I'm sorry.
All right, well,
If there's
thank you,
any-
AC.
If there's any additional questions, we can help facilitate that and get that to IHS.
All right, thank you, AC. We have come to the end of our time, and I want to thank our speakers very much for joining us. And to all of those who shared your thoughts, comments, questions during the session. Director Fowler, do you have any comments, closing comments you'd like to share?
I'd just like to say that thank you for everyone who was able to pose questions and comments today. We do appreciate hearing from you. And as I mentioned in my remarks, it's very valuable to us to hear from you and to understand where we should place our focus and what we need to work on. So thank you for the opportunity to have this listening session during your conference. We are grateful for the time and look forward to continued participation in the conference, and hope that I will say that if you didn't get to ask a question today, perhaps there might be a few minutes during the plenary to also ask those questions as well. I'll leave it with that. Good morning, and thank you again, everyone.
Thank you, Mrs. Fowler. We appreciate you being with us today. We'll be following up with you and your team on the issues discussed today. We know that having this time is important, and it is also critically important that we track the progress of these recommendations. We trust that the agent will help to support our recommendation, and tribal leaders across the Indian country will work to make sure lawmakers also know what our priorities are. We do have several other events today, including the tribal consultation with the U.S. Department of Veterans Affairs, which will be starting shortly at 1 o'clock Eastern time, and a listening session with the CDC and prevention, or CDC, which will start at 2 p.m. Eastern time. We hope that you will all join us for these sessions. Lately, please remember to stop by our virtual exhibit hall and marketplace to see the great offerings and connect with the vendors. Awa'ata, and thank you again for our speakers and the audience members. Please take a few seconds at the end of the session to fill out the evaluation. You can find the link. They say, please fill out this sessions evaluations under the sessions descriptions on the sessions page in the online conference agenda. These feedbacks is critical for the work that the National Health Board does and help us improve our listening and consultation sessions in the future. On behalf of the entire National Health Board, I wish you a good week and hope that you enjoy the rest of the conference. And thank you all for attending, and see you all later.
Thank you.
Bye now.